Whenever you're ready.
Good morning, all. Apologies in advance, ours is not as fantastically interactive as that.
If you fall asleep, we won't be offended.
Yes, absolutely fine. But then maybe sweet, so you know. Patient we're going to talk to about today is Bob. He's a 95-year-old male, and prior to hospital admission, he was independent at home, even being 95. Bless him. His children now live abroad, and sadly, his wife passed away in 2020 during the pandemic. And since then, Bob's social interactions have been quite limited, since his wife was the party animal, the one who got him out and about, and also he's given up driving due to his old age and a bit of frailty. So he finds it difficult to living in a small town to get buses places. So he's a little bit of a recluse at the moment. He's an ex-smoker with a past medical history of angina and has had a previous MI and a slight BMI slightly high at 29. He presented in A&E after an ambulance was called by his neighbour as he had a fall at home, which was witnessed with no obvious head injuries. Bob was unable to safely transfer himself back to the chair off the floor as he was feeling quite dizzy. Now he's presenting as hypertensive with a BP of 89/65 with arterial hypertension symptoms. Tachycardic and paramedics also noted edematous legs. These were previously unseen by anyone and unknown regarding the GP, as he has not been there in over a year. He finds it quite difficult to get on about now. He's also presenting with peripheral cyanosis when the O2 that was put on by the paramedics is removed. The ambulance crew administers 15 litres O2 through a non-rebreathed mask as the initial stats reading 86. Through weaning off in the O2 in ED and on the ward, he's currently on 2 litres of O2, maintaining stats of 98 now. This results in a shortness of breath and a new O2 requirement. His GCA score, however, is 15, and he has been assessed to have full capacity. Regarding the edema, the patient has been catheterised, put on a split for a balance chart, 1.5 fluid litre restriction. He will have daily weights done throughout his hospital stay, which will be done to assess the fluid loss and weight loss. ECG has been done and VVG has also been taken. As he hasn't been to his GP in a while and he was previously independent, his DNR status hasn't been previously discussed, and therefore this might be something that's done on this admission, depending on if he spirals down on admission. He's relatively independent and able to maintain his own ADLs adequately, as far as we're aware, due to the lack of GP input recently. This will be a conversation with this hospital admission with the patient and their next of kin, potentially, if we can, if they live abroad. The initial diagnosis of stage 2 heart failure has been made by the treating physicians in ED. This is not uncommon, as around 690,000 people in the UK are diagnosed with heart failure, with the British Heart Foundation estimating more than 900,000 actually living with heart failure, potentially undiagnosed, and 64% over the age of 75. So Bob's done pretty well just to get to 95 with a bit of heart issues. And the goal on his discharge, hopefully, will be successfully back to his own home, as that is his wishes, depending on the outcome, length, and any deconditioning that may happen for Bob during the hospital stay. A palliative care and care plan will have to be put in place to make this possible. At the very least, we'll have a small palliative care and a referral to a heart specialist failure team out in the community, just continue support if need be. His mobility and pulmonary deterioration will have to be taken into account, depending how long he's with us on the ward, how we can get him up and moving, and physio input will also be needed. We will now go into the pathophysiology.
In a healthy heart, there are 4 chambers, a left and right atrium and a left and right ventricle. The superior vena cava drains blood from the head and the arms, and the inferior vena cava from the body and legs. The right side of the heart receives oxygen-poor blood from the rest of the body, and the left receives oxygen-rich blood from the lungs. The 4 chambers are separated by one-way valves that open and close to prevent the backflow of blood. When there's normal cardiac function, the heart is a muscular organ. It metabolizes tissue in the body that requires a constant state of blood for nutrients and removing waste products. When the heart operates correctly, the blood supplied by the heart to the body's tissues is matched to the rate of oxygen necessary for biochemical processes to take place. Blood enters the heart's atrium and is pumped to the right ventricle, which in turn pumps blood to the lungs. The pulmonary artery then carries the unoxygenated blood from the heart to the lungs, where the lungs add oxygen to the blood. The blood then travels back to the heart through the pulmonary veins, the left atrium, the left ventricle, and out of the body's tissues through the aorta. Indicators of a normal heart function include normal blood pressure, a normal pulse of about 60 to 100 beats a minute, good perfusion, which can be found in your oxygen sats, so any sats above 96%, somebody who is pink and well perfused with a capillary refill of less than 3 seconds, and respirations from anywhere between 12 and 20. A healthy cardiac cycle consists of ventricular contraction and ventricular relaxation. During contraction, the left ventricle ejects blood from the heart. Heart failure represents a decreased ventricular function, which can be caused by a thickened myocardium. It can be caused by past heart problems. In Bob's case, they're not 100% sure what was causing it, but sometimes a healthy lifestyle can counteract heart failure. So it could have been from a history of smoking, alcohol use, drug use, or poor healthy lifestyle. An ECG can be used to assess the function of the heart. A healthy heart can be indicated again by 60 to 100 beats a minute, a regular rhythm, evenly spaced, and a present PQRS complex, as shown here. An absent P wave presents irregular rhythm and is a suggestion of AF, which can be found in people with heart failure. In a healthy heart, the ST segment should have an isoelectric line, so it shouldn't be either elevated or depressed. This healthy ECG is in sinus rhythm. Bob's wouldn't look like this due to his increased heart rate, low blood pressure, and possible irregularity in rhythm, which could suggest AF. On admission, blood tests can be taken and investigations can be made to confirm or exclude heart failure or exacerbation of heart failure. The doctor may check for a protein that the heart secretes to keep the blood pressure stable, which increases with blood pressure. Cholesterol levels can be checked to indicate heart failure, and use an ESA measured to assess the level of electrolytes and the function of the kidneys.
So when a person has heart failure, the pathophysiology can look different to that of somebody that's got a healthy heart. So lack of function in the heart can cause an inadequate supply of blood to the body's tissues, hence why Bob's got cyanosis, because his tissues aren't being perfused properly. Heart failure can occur as a result of coronary heart disease, heart inflammation, hypertension, cardiomyopathy, or an irregular heartbeat. Symptoms of heart failure include shortness of breath, wheezing, fatigue, coughing, swelling or edema in legs and feet, rapid heart rate or irregular heart rate. So the heart becomes damaged by primary causes from injury to the myocardial muscles. Heart failure decreases the body's stroke volume and overall cardiac output, leading to neurohormonal response. In turn, the heart vasoconstricts and retains sodium and fluid, which is why you get the edema, swelling to the legs and feet. Increasing vasopressin and aldosterone. Sorry, I can never say that word. Ultimately, the heart failure places stress on ventricular walls, leading to worse ventricular function and further heart failure. So, like Morgan said, an ECG cannot confirm or exclude heart failure. However, irregularities on an ECG can be indicators of cardiac weakness and promote the necessity for further investigations, such as blood tests, which Morgan said. Chest X-rays, however, can be used to assist with diagnosing, along with other things like an ECG and blood tests, and how they're managing their ADLs. An increased size of the heart, fluid on the lungs, or lung condition would be indicators of heart failure. Congestive heart failure causes one or both of the lower chambers of the heart, so the ventricles of the heart, to stop adequate movement of blood. Blood can therefore end up backed up in the legs and ankles, again with the edema. So obviously again with the cyanosis, because Bob's requiring a new requirement of oxygen.
So that occurs because of a result of limited oxygen in the blood. So obviously Bob's been put on a 15 litres non-free breathe with this poor perfusion of oxygen into his tissues. So he may appear grey or blue as a result of the poor perfusion, and have cold fingers and toes. Obviously you can't use the saturation probe on his fingers, so you're probably going to have to use the ear probe to get the sats reading on a patient such as Bob.
Okay, so as you can see, it's really important to have a great understanding of the pathophysiology with a person with heart failure, as stated by Saskia Morgan. So following on from this, we'll be concentrating on the vascular system and how this impacts on the kidneys. So what you need to start questioning yourself is, why is vascular homeostasis important? The best way I can think about teaching this to you is to imagine the M25 at the peak of summer. The M25 represents the vascular system, and the cars are the blood filled with nutrients and unable to go anywhere. The peak of summer represents the lack of hydration to the vascular system, and the car pile up or accident further down the road is an AKI. So homeostasis is not being maintained, and this can lead to an impending heart attack where the body gives up. So our next step in acute hospitals is to do something called a drying out process, which is removing the offloaded fluids build up in the body. So it's really important to keep the vascular system lubricated. However, for our example, Bob, he's elderly. So by removing the sodium and potassium, it can cause hypokalemia, and the magnesium replacement is often prescribed as it also aids with the electrolyte balance. So patients with heart failure present with overloaded edema, and sodium is the body's natural way of reabsorbing the interstitial fluids. So in the hospital, we make the most of our multidisciplinary team, and we also ask for help with our nurse specialists. We ask for our doctors to do a daily review and for our heart specialists to support whilst the drying out process occurs. We'll be conducting daily weights to monitor the fluid overload, preferably in the morning, wearing similar clothing to ensure accuracy and safety when balancing the hydration of the vascular system. The electrolytes balance, and we're also going to be asking Bob to be on a sodium restrictive diet. So today I'd like to trial something a little bit different. So can I have some offers for some of the audience to be police officers, fire officers and party animals, please? So if you just like to decide, you know, when I shout out again, if you could put your hands up. So thank you very much. So police officers, can I have some hands up? Thank you. So you're going to be clearing the traffic by administering the IV freezamide, okay? The freezamide eradicates all the interstitial fluid. It works by blocking the sodium absorption, chloride and water from the filtered fluid in the kidneys, tubules, causing an increase of diuresis, which is increased urine output. The absorption is slower than normal in patients with edema and heart failure. However, the amount of loop diuretic absorption is normal. So for the metabolization, basically it's a frusemide, fluoretinide. It's a major biotransformation active product, which causes the diuretic effect, and it's metabolized in the liver. So there's half-lives and full lives of medication. Half-life is the short-acting immediate response. So this is for frusemide for 2 hours, and the total therapeutic time is about 6 to 8 hours. So this is where we start to see the urine come out of the body and the fluid overload eradicating. However, it will prolong in patients with chronic renal disease. So it's a really fine balance that we need to maintain. So too much furosemide can cause something called nephrotoxicity, which is ultimately where the kidneys just fail. And it can also increase the risk of a heart attack as well. So party animals, where are we? So this is your IV iron therapy, which helps with the infarction of the heart. With patients with heart failure, the iron is depleted in the body. The full understanding isn't really known, and there's several arguments out there that I'll leave for you to research if you wish afterwards. So following the IV administration, it's taken up by the cells with the reticuloendothelial system, particularly in the liver and the spleen, where it's stored. And again, the plasma has a half-life of about 5 hours, which is uncirculating, and where it's going round our vascular system, it has about 20 hours effect. The iron replenishes the hemoglobin and the depleted iron stores. Due to the size of the carbohydrate iron complex, it's not eliminated via the kidneys, and small quantities of the iron are eliminated in feces and urine. So if it's not accurately calculated on the body, you can actually poison your patients. So you need to start looking for signs of nephrotoxicity. Okay, and lastly, can I have my fire officers? Woo woo, thank you. So after this process, we're starting to put our public health hats on, and we're going to be educating with the help of our heart specialist nurses about maintenance. So first of all, we need to replace the IV furosemide to a daily diuretic, which is butamide. It's kinder to the kidneys, and is like a diuretic, but you have to inform your patients about issues with interactions with alternative medication, because it can cause hypotension, hypokalemia, hyperanemia, and toxicity. In particular, the potassium can be lost in the blood, therefore continuous monitoring in the community via bloods needs to happen. If this process is not maintained well by the MDT and the heart specialist nurses, renal failure can occur. So it's really important to check bloods on a daily basis. In particular, you can start looking at your thyroid levels, because thyroid affects the function of the heart. Daily weights, and accurately promoting effective treatment for our patients. So minimize overpose button. Sorry.
Fourth one along,
Thank you.
and then it's the second one, I think. No, the one. That's it.
So this is an example somewhere in here on my lovely wallpaper, I called it, is under a microscope of the ductal part of the kidney, and this is the part that's affected by the crystalloids in the medication, and it will break down in the kidney. So just, I thought it was a pretty picture, so thank you. Over to you, Tammy.
So another thing that can be prescribed for our patient Bob, because he had a low blood pressure and because he wasn't going to be mobilising massively while he was on the walk, the doctors prescribed him intermittent pneumatic compression devices because of his lack of movement. However, the nursing staff felt that due to his needing to use the commode on a regular basis for the furosemide, this would actually, within the nursing process, made him more likely to have a fall. Therefore, it was discussed with the nurses, and they changed that prescription to compression stockings for two reasons. Obviously, to for the edema and for the blood flow. The reason for that is obviously the heart pumping the oxygen-rich blood to all parts of the body through the arteries. Once it's provided the nourishment to the given areas, the blood needs to pump the heart needs to pump the blood back to the body's veins. Because the blood in the legs has to fight gravity and travel the furthest distance back to the heart, its flow occasionally becomes impaired. So compression socks improve the blood flow by squeezing the legs and helping the veins push the blood back to the heart. This pressure also helps the blood from pooling in the lower extremities. The compression on these stockings also moves any swelling that can be present throughout the body's lymphatic system and out of the infected regions. Obviously, within the timescale of this presentation, it's not possible to discuss the lymphatic system and all the structures having had the previous descriptions. I mean, other benefits of the stockings are obviously the diminished blood clot, the likelihood of a blood clot, the prevention of venous ulcers, decreased swelling, and enhanced recovery. As Lucy previously discussed, patients receiving any kind of diuretic require monitoring of blood due to the fact that the kidneys excrete not just the unwanted fluids, but the potassium, sodium and magnesium. And when in hospital, doctors need to consider the balance of fluids and the loss of electrolytes when prescribing any kind of IV fluid. Therefore, it's much better when we are able to encourage our patients to take on oral fluids with strict monitoring. All IV fluids are obviously drugs requiring a prescription. It can have serious negative effects if not given correctly. In actual fact, there's as many as 1 in 5 patients on IV fluid therapy may experience complications of being given too much or too little, and some of those complications can be fatal, and that comes from the inquiry into perioperative deaths. Patients on IV fluids should have a management plan which also includes details of their fluid and electrolyte prescription for 24 hours. Patients are likely fluid and electrolytes should be assessed by their history. For example, whether they've had the limited fluid intake, whether they're thirsty, what and how much of the type of fluid they could have lost, also by clinical examination. And health professionals should consider the IV fluids for routine maintenance during daytime hours to promote sleep and well-being, and obviously prevent falls and things as well. Luckily, our Bob he was able to eat and drink normally, so we were able to not have to do any of that, which is quite bonus really. But yeah, it's important to acknowledge the 5 R's of IV fluid therapy. And in the case of Bob, if he had have needed IV fluid therapy, it would have been for redistribution, which is on a heart failure patient quite complex. And due to the lack of shift of fluid within the body or too much or not enough. So at that point, it's important that the fluids for this patient with a complex needs we want to discuss with the heart failure nurses or the heart failure team. That is the 5 hours of IV fluid. Just to have a little look at. Amy.
So to finish off, we have a fun true or false quiz for everyone, and points being prizes.
Size chocolate.
Yeah. So just a true or false quiz. So true or false, is weight gain an indicator of heart failure? Shut up.
Yeah.
It's very bad.
Okay. Second one is true or false. Irregular heart rhythms are called arrhythmias. Irregular heart rhythms are called arrhythmias. True or false?
True.
Way!
You're not.
True or false? A lack of white blood cells is called anemia.
False.
And what's the right answer? True or false? Dilute diuretics encourage calcium retention. Diuretics encourage calcium retention. True or false? It is false.
Got some great throwing skills.
And last one is true or false? Can a pacemaker be used to control heart failure symptoms?
False.
I thought it's true.
It is true.
No.
We don't.
I like that.